The following Pharma Essentia podcast is intended for informational and educational purposes only and cannot be considered as medical advice. Please speak to a healthcare professional before making any treatment decisions.
Hey, Josh.
Hey, Kay. Long time no podcast.
I have missed this, and you, listeners.
We've missed you, and we're so excited to welcome you back with episode 7 of
the PV Pod, Stories from the Marrow,
a podcast about Polycythemia Vera.
Brought to you by Pharma Essentia.
Thanks, Pharma Essentia.
Josh, when's the last time we had a chance to record?
Our last episode was in February. We had that great conversation recapping everything we've learned so far about PV.
Right, that was a fantastic episode.
For anyone joining us for the first time, we highly recommend you go back and listen to that one just to get you up to speed with everything.
What's an area you've grown in the past few months since we last spoke?
Okay. Well, I've been taking this color correction course for film and documentary work, and I've been really enjoying the process of taking dull-looking footage and making it bright and happy. What about you, Kay?
I'm actually taking piano lessons for the first time. I can do most of my scales.
Whoa, I love that. Wait, but I have to ask, what does this have to do with PV?
Well, just like how we as people can progress and change over time,
so can PV.
Exactly. This episode, we're talking about the potential progression of Polycythemia Vera.
Potential progression, meaning?
Not everyone's PV progresses necessarily, and not everyone's progression looks the same.
Okay, I already have a bunch of questions.
Which means it's a good time to introduce you to our guest today.
My name is Douglas Tremblay, and I'm from the Mount Sinai School of Medicine in New York City, where I'm an assistant professor and a member of the MPN and leukemia group there.
Thank goodness. I have so many questions. Where does Dr. Tremblay think is a good place for us to start?
Just so we're all on the same page, we first asked Dr. Tremblay to define progression in Polycythemia Vera.
Yeah, okay. That was definitely one of the big things I was wondering about. When you say progression in regards to PV, what exactly does that mean? I feel like that can mean so many different things.
Well, you're right.
There's many ways to define progression in Polycythemia Vera, although there really lacks a unified definition where we can really say this is what progression is.
Wait, hold on. How can we talk about the progression of PV when there isn't one definition of what it is?
Dr. Tremblay has got you covered.
I'll give you some examples.
Perfect. I love examples.
The most clear example is when Polycythemia Vera turns into a different disease, such as myelofibrosis,
a different blood cancer,
where there's scarring of the bone marrow, and instead of high red blood cell counts, there can be low red blood cell counts or low counts and more significant symptoms. And that's a different disease that patients with Polycythemia Vera can transform into. Or an even more aggressive version called acute myeloid leukemia, or MPN blast phase. So transformation from one defined disease state to another defined disease state is one way progression is defined. And frequently when physicians speak about progression, they're really speaking about this.
So sometimes PV becomes myelofibrosis or acute myeloid leukemia, which is more aggressive.
Correct. And this change from one disease state to another is called transformation, which is more specific than progression.
Wait, so then what's the difference between transformation and progression?
Transformation in PV really means switching from Polycythemia Vera to myelofibrosis or acute myeloid leukemia or a different disease like myelodysplastic syndrome. But there's progression. So I view progression more as a patient-centric sort of discussion, and transformations really, do you tick off all the boxes where your disease is no longer Polycythemia Vera but is a different disease?
Okay, so if this transformation is different than progression, how should we think about progression in regards to PV?
Someone who doesn't have a blood clot and then develops a blood clot, or someone who has a blood clot and develops more blood clots, I would define that as someone who may be progressing. Or if someone has minimal symptoms from their Polycythemia Vera, but then they become much more symptomatic, that's another way that I would say someone is progressing, developing more symptoms. Another way is by knowing how many phlebotomies, bloodletting that patients get for treatment of Polycythemia Vera. If that starts to increase, that could be a sign of progression as well.
This makes sense to me. Progression can just be how your PV changes over time. You can go from having no blood clots to developing blood clots. You can go from fewer symptoms to more symptoms.
Right. Progression doesn't always mean changing from one disease state to another. That's just transformation.
Is there any other way we should think about progression?
As physicians, we look at many different sort of tests on the blood or the bone marrow to see if there's changes in the molecular complexity of the actual disease at the level of the bone marrow, which the disease originates from, and see if that is advancing or changing as well. So while there's the kind of classic definition of progression, which is transformation from polycythemia vera to myelofibrosis or AML, acute myeloid leukemia, there's many different ways which a patient can also have other clinical progression, and I think that's really important to discuss and to be on the lookout for.
Got it. There's symptomatic progression and cellular progression in addition to disease state transformation. Symptomatic progression makes sense to me, but I'd like to talk a little bit more about cellular progression. What is that?
Sure. To understand how things can progress on the molecular level with PV, I think it'll be helpful to establish what is normal cellular activity with PV.
So in normal PV, at the proliferative phase of Polycythemia Vera, there's the presence of the JAK2 mutation, which is present in over 95% of patients with Polycythemia Vera.
Could we do a quick refresher on the JAK2 mutation?
Sure. JAK2 is a gene found on the 9th chromosome that provides the instructions for making a protein that promotes cell growth and division. Almost all patients with Polycythemia Vera have a mutation on the JAK2 gene.
And that really causes a lot of issues within the bone marrow, within the signaling of the bone marrow through different signaling pathways in the cells that culminate into too many red blood cells being made and too many precursor white blood cells and platelets being made. And that causes the issues that you have with polycythemia vera, both the blood counts where you have too high of a hemoglobin or hematocrit, but also this JAK2 mutation causes a lot of these things to be made called cytokines, which can cause symptoms that are experienced by patients with polycythemia vera, such as fatigue or itching, and it also can cause a big spleen in patients with polycythemia vera who have a big spleen. So this mutation is really important, and many different features at the level of the bone marrow can create the environment where this mutation can expand and cause the disease.
So if that's normal for someone with PV, what's abnormal? What's going on when cellular progression is occurring?
What we think happens is that in some patients, this JAK mutation causes this inflammatory scenario in the bone marrow that can start disrupting certain processes and kind of make the bone marrow more of a toxic environment that eventually causes some of the scarring to happen and some of the other factors to happen in the bone marrow that cause myelofibrosis and leukemia. But there's also important to know that in the bone marrow, there's not just one kind of group of cells that are causing the disease. There can be many different populations of cells. And some of the cells in those populations may grow out more and cause the disease to advance. And different mutations, aside from JAK2, may be present in these different populations of cells that give them an advantage to grow out and cause more aggressive versions of the disease. So there's still a lot of work being done to understand what happens in the bone marrow when someone progresses. But some key features are the inflammation, like I mentioned, and these different populations of cells that may have different types of mutations that can allow them to grow more and cause more aggressive disease. And those presence of populations of cells may be present in some patients, but may also be absent in other ones.
It sounds like there's still a lot to learn about progression and transformation with polycythemia vera.
That is true.
Do we know how common progression and transformation is in PV? Like, if you have PV, will you definitely experience one or the other?
It's a great question, and it really depends on which study you're looking at and what population. For one study, for instance, over a 10-year period, about 10 to 20% of patients progress to myelofibrosis. and around 5% will progress to AML. But again, it really depends on what you look at. But I highlight that to note that that's not 100%. It's not even 50%, and that progression is really an event that occurs over a long period of time and occurs in the minority of patients, not even 50% of patients, about 10 to 20% of patients.
To summarize, about 10 to 20% of patients experienced transformation to a different disease state, and that was over a long period of time, 10 years.
So transformation isn't guaranteed or even common.
Perhaps, but 10 to 20% is still a very real and significant number of patients. And patient anxiety surrounding progression or transformation is also very real as well.
That makes total sense to me. I mean, what if you're one of the 10 to 20%? That's a natural trigger for anxiety and a good reason to be informed about PV's progression.
And we'll continue our conversation with Dr. Tremblay right after this quick break.
So you're learning about PV on the PV Pod, Stories from the Marrow. Now get ready to take the next steps on your PV journey with What's Next PV, an educational site on everything polycythemia vera.
Knowing what's next can help inform the decisions you and your doctor make about the future and is important to your health. What's Next PV can help you understand test results, set goals for the management of your PV, and make a plan to advocate for yourself. Check out www.pvbonemarrow.com to learn more.
Welcome back.
Before the break, we established what progression in PV can look like and the difference between progression and transformation.
So this is what I started wondering about during that break. Some people's polycythemia vera progresses and others don't. If I had PV, I would want to know, are some people with PV more likely to progress or transform than others? And are there any risk factors that might make my PV more inclined to progress?
That is a great question. And unfortunately, one that isn't so easy to answer.
There may be patients who I watch a little bit closer because I'm worried that they're at risk for progressing. And there's other patients who may be less likely to progress, but that doesn't mean that the patients who are more likely to progress will progress, or that the patients who are less likely to progress won't progress. So there's a lot of different features that go into this, and there's no way to really tell any individual patient. We don't have a crystal ball to say you will progress or you will not progress.
So it's quite difficult to perform the study necessary to answer your question fully.
A moment ago, Dr. Tremblay mentioned there might be patients he watches a bit closer because he's worried about the risk for progression. If we don't really know how to determine which patients will progress and won't, how does he know which patients to monitor more closely?
So it's generally poorly understood, but there's a few things that have been pretty well validated in the literature to suggest that this is something that is a risk factor for progression. And one is having a high white blood cell count. That's been shown to be a risk factor for progression in multiple analyses, including some we've performed as well. The other thing that has been associated with a risk of progression is having a high amount of the JAK2 mutation, especially if it's your burden of the JAK2 mutations over 50% of your cells. That's been associated with a risk of progression.
Your burden of the JAK2 mutation. What does he mean by that? Your burden.
He's referring to your allele burden.
Which is?
Allele burden is the proportion of cells that have the mutation. So it's a number that's out of 100. So 100 would mean 100% of the cells have the mutation. And 50 may suggest really represents about 50% of the white blood cells have the mutation. And it's a way for us to quantify, to really measure what percent of the cells are affected by a certain mutation.
So what Dr. Tremblay was saying was that if you have a high allele burden with PV, over 50% of your cells carry that JAK2 mutation.
And that affects your risk of progression with PV?
High allele burden above 50% is associated with progression. So if you have a higher allele burden, in addition to being associated with other features and complications of polycythemia vera, high allele burden greater than 50% is associated with an increased risk of progression. And then other factors that have been associated is certain burden of other mutations outside of JAK2. And the presence of those mutations also may suggest that there's an increased risk of progression as well.
Other mutations or allele burdens outside of the JAK2 burden can also increase your risk of progression.
You got it.
So when you do experience progression with your PV, how does that affect your initial prognosis?
Progression is a very important prognostic factor in PV because once your disease progresses from polycythemia vera to myelofibrosis or MPN blast phase, these are diseases that carry a worse prognosis than polycythemia vera. And in the case of AML secondary to polycythemia vera, leukemic transformation in polycythemia vera, that really carries a very poor prognosis. And so it's very important to understand the risk factors and be monitoring for this as well.
So, unfortunately, transformation of PV can result in a worse prognosis.
But this isn't very common.
Even so, this is a major reason to be aware if you're at risk for progression or transformation, and to make sure you're monitoring your symptoms, as Dr. Tremblay said.
It's also important that the goals of polycythemia vera treatment are generally to prevent thrombotic events from happening, preventing blood clots. But whenever your disease progresses to myelofibrosis or leukemia, your goals of treatment really change. And now we're really trying to prevent the disease from getting worse and also improving survival and other outcomes such as that. And thrombosis kind of takes a back seat. So it really fundamentally changes the way we really think about treatment for the disease once the disease progresses.
Yeah, this makes sense. In past episodes, we've talked about how treatment for PV is centered around symptom management and clot prevention.
So when your PV becomes something else, like myelofibrosis or leukemia, your treatment and your goals of treatment change as well.
Would you ever try to stop or prevent progression? Is that possible with PV?
That can be a bit of a challenge.
Why?
There's several reasons why it's difficult to reverse prevent progression. And the first is that it's difficult to define progression. It's difficult to measure progression. These are chronic diseases, thankfully, with polycythemia vera, and patients live for a long time. And in order to really measure and understand how frequent and what the risk factors are for progression, you need to follow a large group of patients for decades to really get a handle of this. In addition, patients with polycythemia vera are not all the same. Many patients are different in fundamentally how the disease presents on a cellular level, how the disease manifests in symptoms and complications. And so there's a lot of heterogeneity, and that makes it very challenging to understand what the causes and how to prevent progression. But it's also a feature that for many years we've had a lack of treatments that really affect the underlying stem cell clone, underlying disease mechanics in the bone marrow. And so historically, if we've had challenges to try to prevent the disease progressing, it's also because we've had challenges because we haven't had medications that really are good at suppressing that underlying polycythemia vera mutation, JAK2 mutation clone, and really preventing the disease from progressing.
To summarize, as we mentioned earlier, it's difficult to organize a study of progression for PV due to how long progression lasts, which can be decades.
It's also difficult to understand because there's a lot of differences in how PV presents from patient to patient. I would imagine that the uncertainty surrounding PV, while it's understandable, is really concerning and frustrating for people living with PV.
The number one concern patients have is really progression. In one study, was about 25% of patients listed it as their number one concern if they have polycythemia vera. In contrast, only 4% of doctors who treat patients with polycythemia vera list it there as their number one concern. So I think it's really important to listen to patients and understand that this is a huge concern. I hear patients using phrases like it's a ticking time bomb or a lot of uncertainty about if this is going to happen. And so patients are really worried about the disease becoming more serious and more dangerous.
Exactly. That makes a lot of sense. I know earlier we said it's difficult to study, but if I were a PV patient, I would want to know how progression might be prevented.
So we discussed how the JAK2 mutation is really important for the disease turning from polycythemia vera into more aggressive versions. And so one way to prevent the disease on a cellular level from progressing is to control that amount of that JAK2 mutation and reduce the amount of that JAK2 mutation. The other ways is, as I mentioned, inflammation in the bone marrow is really important too for the disease progressing as well. And giving medications that can really reduce the amount of inflammation in the bone marrow is also a really important way. And ultimately, trying to target that JAK2 mutation as well as other clones that are in the bone marrow to really effectively eliminate those sort of bad cells while maintaining the good cells of the bone marrow, that's really an important way to prevent progression on a cellular level.
And are there any treatments that can do this, that could prevent or delay progression?
So this is controversial. I mean, the ultimate treatment for any of these blood diseases is a bone marrow transplant, which cures the disease, but it's associated with many patients getting very sick or even dying during the treatment, and it's a very morbid procedure. So we don't recommend this for patients with polycythemia vera. There are certain cytoreductive therapies and treatments that may prevent progression, and this has been established in a number of different studies. And the amount that they really prevent progression, or the how much this really prevents progression, is still a matter of debate. But it is becoming clear that controlling the amount of that JAK2 clone may actually prevent the disease from progressing. And more work is really needed to know which of these treatments are the best and to what degree they really prevent progression, because they may reduce the level and reduce the risk of disease progressing, but I don't think any of them have been able to really make a claim that they eliminate progression from happening. So whether they reduce the risk of progression, they don't eliminate it all, right?
So this sounds like another instance where there's still a lot to learn.
That is the case.
So I think that the important thing that I tell patients is that we are learning more and more about this disease every day. And in particular, there's a large effort to really look at progression in polycythemia vera and see how we can really counteract this march towards progression that some patients are on, and how we can really intervene to try to prevent progression. And that also involves developing new drugs and new therapies that can one day prevent the disease from progressing. So there are many therapies that are on the horizon that may one day significantly reduce the risk of progression from occurring. And more work is needed to be done, but there's a dedicated group of researchers, including myself, that are really focused on these questions to try to improve not only lifespan, but the quality of life of patients with polycythemia vera.
It can be really frustrating to hear how many unknowns there still are with polycythemia vera. It's good to know that people like Dr. Tremblay are working on it and keeping us informed as new information about PV comes to light.
Agreed. All the time, we are getting better at understanding and treating polycythemia vera.
Just like how all the time you're getting better at piano.
Ah, full circle. Thank you, Josh.
You're welcome, Kay.
And thank you, Dr. Tremblay, for sharing your insight and expertise with us.
And thank you, listeners, for joining us for another episode of the PV Pod, Stories from the Marrow.
See you next time.
Can't wait.
The PV Pod, Stories from the Marrow, is produced by Believe Limited and Bloodstream Media, and made possible thanks to our sponsor, Pharma Essentia. The PV Pod is hosted by me, Kay Vermeil, and my co-host, Josh Bragg. If you like the show, please share it with anyone for whom it might make a difference, and leave us a rating on Apple Podcasts or Spotify. We'll see you next time.